Good afternoon. I would like to thank the organizing committee for giving me this opportunity to discuss with you recent updates on the oocyte vitrification for fertility preservation for non-medical and medical reasons. This is my disclosure. So fertility counseling is part of best practice recommendations for women at high risk for infertility or premature ovarian insufficiency. The infertility risk and the possibility of fertility preservation should be addressed when the intrinsic effect of a pathology or its treatment puts the woman's fertility at stake. So who are at risk are young cancer patients who will be treated with chemotherapy, radiotherapy, or ovarian surgery, and women with benign pathologies which may account for 8 to 13% of indications for fertility preservation. So just to review with you the different fertility preservation interventions. So we have oocyte cryopreservation, which is the bulk of our lecture. So this is the method of choice for women undergoing treatment for age-related fertility decline, or what you call elective egg freezing. And for most women undergoing fertility preservation for medical reasons. Embryo cryopreservation has long been established as a fertility preservation technique. However, the necessity for joint legal ownership with a male partner is an important consideration that may result in difficulties later. Ovarian tissue cryopreservation is an important option, especially for our younger patients, or if there is insufficient time for stimulation of the ovaries before oocyte cryopreservation. And lastly, IVM, although this is not available in our country, it can also be considered and sometimes combined with the other techniques. Okay. So a brief history on how oocyte cryopreservation came about. So in 1986, were the first slow freezing twins delivered. Okay, and then in 1999, the first birth following the much improved oocyte vitrification happened. In 2012, ESHRE, and then 2013, ASRM removed the label of oocyte cryopreservation as being an experimental method of fertility preservation. In 2014, ACOG started actively promoting the utilization of oocyte cryopreservation, and most recently, in 2018, in the Ethics Committee guideline of ASRM, they narrated that planned oocyte cryopreservation is ethically permissible. Okay. So now the oocyte cryopreservation is a boon to ART. Okay, its availability has improved the safety and efficacy of ART cycles. It took 3 decades for this particular method to have positive outcome, comparable pregnancy outcomes with the other embryo cryopreservation. So the progress of the evolution of this technique is mainly due to the technical concerns, due to the unique structure of the mature oocyte. Being larger in size, it has a low surface area to volume ratio, it has a high water content, thus prone to crystal formation and special intracellular content and structure. So it's more cryosusceptible due to intracellular ice formation, membrane damage, depolymerization of microtubules, and hardening of the zona. The success rate has markedly improved by replacing the slow freezing method with the ultra-rapid vitrification, which is now commonly used, and the utilization of ICSI for fertilizing our frozen thawed oocytes. So looking at this systematic review and meta-analysis done by COBO, assessing the superiority of vitrification versus slow freezing. Okay, so if you see here the results, let's concentrate on the results. There is a higher oocyte survival rate with vitrified oocytes, higher fertilization rates, and higher top quality embryos, 22% versus 8%, with the vitrified versus the slow frozen oocytes. There is also high embryo cleavage rate at day 2 and day 3 compared to the slow freezing oocytes. And when we compare the vitrified versus fresh oocytes, the pregnancy rate, the embryo cleavage rate, and the fertilization rate were comparable. Okay, so this is now the method of choice, the vitrification. Okay. So what are the clinical applications of oocyte cryopreservation? So there are 2 main indications. One is medical and non-medical. So medical, top priority, of course, is cancer-related. So for the common breast, hematologic, and gynecologic cancers, okay, presence of genetic diseases which predisposes to premature ovarian insufficiency, so Turner syndrome, Fragile X syndrome, non-malignant but medical indications such as endometriosis, benign ovarian cysts, okay, and those autoimmune diseases wherein they will have a gonadotoxic treatment during their flare stages, which can also render them infertile. Also in occasions where there is failure to obtain sperm on the day of the egg retrieval. So in cases wherein their partners is azoospermic, there was no sperm retrieval on testicular surgery, or there was ejaculatory dysfunction or unavailability of the husband on the day of oocyte retrieval. For non-medical indications, so this is what we call the planned oocyte cryopreservation or elective egg freezing, elective fertility preservation, which is an age-related fertility decline. So the other non-medical indications are for egg banking. So in countries where donor oocyte program is allowed, then they use this. Also for autologous oocyte pooling in poor responders, so you can keep doing your stimulation protocols to retrieve more oocytes. Other non-medical indications are the newer indication, which is a planned female-to-male transition for transgender men. When there is traumatic injury or unanticipated future events like death of an existing child, divorce, or remarriage, then the oocyte cryopreservation becomes a possibility. Okay. So now let's discuss first the oncofertility, so the cancer indication. So as much as 10% of the malignancy occurs in women younger than 40 years of age. And with the improvement of cancer treatment, these women will get to enjoy their remaining years and will need to start family soon. That's why oncofertility preservation is now more in demand. So we know that cancer or its therapy is detrimental to female fertility, either due to the surgical removal of ovaries or use of gonadotoxic drugs which reduce ovarian reserve. Both chemotherapy and irradiation damage the ovary and increases the risk of premature ovarian failure, even early menopause, other ovarian endocrine disorders, or sub or infertility. Thus, mature oocyte freezing is now the most promising strategy for fertility preservation before starting our chemotherapy. Okay. In the 2020 fertility preservation guidelines of ESHRE, they categorized women as to having a high risk of being rendered infertile because of gonadotoxicity induced by cancer treatment, okay, from high risk to low risk. So if we will look at this table, we will see that for all cancer types, whether it be lymphoma, breast cancer, the two most important risk factors influencing the risk of treatment-induced gonadotoxicity are the use of alkylating agents, meaning if alkylating agents are used, they are more at high risk for permanent amenorrhea, and the older age at the time of treatment. So if the woman is in the late 30s or 40s, then she is at higher risk, okay? Now looking at the non-cancer indications for fertility preservation, we have mainly four. So hematologic diseases like thalassemia or aplastic anemia that will also use sometimes gonadotoxic drugs in preparation for hematopoietic stem cell transplantation. We have autoimmune diseases like SLE that may also produce, may also use drugs that can be gonadotoxic. Gynecologic diseases like endometriosis, ovarian cysts, and borderline tumors may be rendered low to moderate or high risk, depending on the presence of endometriotic cysts or bilaterality, or if there were already repeated surgeries, thus diminishing ovarian reserve. Genetic diseases are not as common, but they are high risk for permanent amenorrhea or ovarian failure. Okay? So for the non-oncologic indications, so we mentioned immunologic, gynecologic, hematologic, and genetic pathology. So the ovarian failure can be induced by the disease itself or by the treatment in the presence of the immunosuppressive drugs or surgical treatments involving the ovaries. And the fertility preserving techniques are the same as the oncologic techniques. So it can be an oocyte cryopreservation, embryo cryopreservation, or ovarian tissue cryopreservation. Okay. With regards to gynecologic pathologies, it represents more than 40% of non-oncologic indications for fertility preservation. So the cause may be either a depletion of the ovarian reserve as a result of repeated surgery, or sometimes because of the intrinsic disease itself, like endometriosis. Okay, so endometriosis has been proven to have a direct detrimental effect on the ovarian reserve. Thus, the presence of a diminished ovarian reserve and high risk of recurrence are enough indications to counsel our patients with these benign lesions for possible fertility preservation. Other non-medical indications are, like I mentioned, when you harvested super number of oocytes and you don't want to fertilize all, again, for ethical reasons or for other reasons, then you can fertilize a certain number of oocytes and store the rest as oocytes. So you do not have all embryos frozen. If there is an unexpected unavailability of the sperm at the time of retrieval and this relatively new indication, which is a planned female to male transition. So this cryopreservation for transgender men. So transgender men are those who were assigned as female at birth and then transitioning to men. So they are the ones who will take the testosterone, and in the later time, they will have their reproductive organs removed. So they may have that option of doing oocyte cryopreservation. So this is largely dependent on the phase at which they are in their treatment. So you can offer oocyte cryopreservation if they're still undergoing, they're not doing surgery yet, or ovarian tissue cryopreservation at the time of surgery. So for controlled ovarian stimulation, the recommendation is to use an antagonist cycle paired with the letrozole to lower the estrogenic symptoms from ovarian stimulation. So now let's go to non-medical oocyte cryopreservation. So this is an elective method of fertility preservation, mainly for age-related fertility decline. Okay, so let's just review the terminology. So the general term is oocyte cryopreservation. This is a generic term. It's generic in the sense that it does not give us the rationale or the indication for oocyte cryopreservation. So social egg freezing elective, these terminologies are more common to the lay. However, it sort of trivializes the indication and increases the negative stigma. Okay, so the UK specialists are recommending using oocyte cryopreservation for anticipated gamete exhaustion. So this is a form of like a preventive medicine for age-related fertility decline. The ASRM group is using planned oocyte cryopreservation as the terminology. Okay, so that is the indication. We know that the age is the most predictive marker for ovarian reserve and ability to conceive. And there is a decline in fertility that can start as early as 13 years prior to the onset of menopause. And in 10% of women, the accelerated decline can even happen as early as 32 years. And some patients, they already have this non-oncologic conditions, which again further increase their risk of having an earlier fertility decline. Okay, so let's correct the misnomer that IVF corrects the aging biological clock. It does not. So if you see here in the bar graph, you will see that even the IVF success rate is also compromised as the woman enters her 5th decade of life. That's why age is the most important prognostic factor for success in IVF outcomes. And we also know that as the age rises, the incidence of aneuploidy also rises. So the lowest risk for aneuploidy is in the 20s to 30s, and then there's already an exponential rise until the age of 43, where you can quote an 85% risk of aneuploidy. Okay? So these are famous local celebrities who publicly admitted that they did social freezing, and there is an increasing trend now. So mainly due to these following reasons. First, more women are pursuing education or more education and better opportunity in the workplace. There is also a concern of rising costs of childbearing, housing factors, being too busy at work, and also the wish of some men to delay parenthood. There are studies like that. But the most glaring reason for elective egg freezing is a lack of a current partner. So in this systematic review of 35 studies assessing the attitudes of women who undergo oocyte freezing, they say that the motivating factors majority is the lack of a suitable partner. Some fear, regret, okay? Career advancement is not a strong motivating factor, okay? And 70% of women undergoing oocyte freezing for non-medical reasons were single at the time of freezing, and cost is a predominant concern. Additional finding from this review is that positive or influencing factors are social views, media coverage, success rate of the IVF clinics, and the risk to health, meaning the younger they are, they get the eggs, the lesser their complications or comorbidities. Deterring factors are the social stigma, the high financial cost, and the health of the future's offspring, which is not that definite yet. Okay. So what is the profile of our patient who wishes to go elective egg freezing? So these are the highly educated, usually they're university grads, they are professionally employed, they're between the ages of 36 to 40, they are not in the relationship at the time of egg freezing, they express their desire to get pregnant. Ideally, they want really still a partner, but they would also consider the use of a donor sperm if there is no partner. So what is the best age or timing to do elective egg freezing? So the two most important factors are the woman's age and the number of mature oocytes. There is no exact age. So one study is recommending that the optimal time is under 35 years. We know this for a fact because the younger you are, the lesser the dose of the drug, the higher the quality of the oocyte. What is the risk of too young? The risk of the woman may not use them. That's why we do not encourage women younger than 30 to store their eggs. Okay? If they do egg freezing at an older age, then they run the risk of having higher doses and poorer oocyte quality. So some studies show that age range between 32 to 37 or 36 to 38 at the time of cryopreservation are ideal, with little benefit if we do it too early, meaning at 25 to 30 years old. So if we go by recommendation of ASRM, they are also recommending that to do oocyte cryopreservation in a younger age compared to older women for better results. Okay? However, there is insufficient data to advise women on the optimal age. What about the number? Again, this is also controversial. So an earlier study by Kobo, they recommended that if you have 10 oocytes, the probability of live birth is 60% in younger than 35, but drops to 30% more than 35. So the bottom line here is the older the woman is, the more oocytes we have to harvest. Okay. So in the study of Doyle, so again, we see here the increasing number of eggs, and the recommendation is 20 oocytes for a cumulative live birth rate of 60 to 80% in women 35 to 38 years of age. In a more recent study by Kobo, similarly, 24 frozen eggs to have an 85% cumulative live birth rates compared to only 10 to 15 a 90% live birth rate and 10 to 15 with lesser oocytes. In some mathematical models, so you see here, to obtain a cumulative 75% live birth rate at 34 years of age, you are recommended to get 10 eggs, 37, 20 eggs, and 42, 61 eggs. That's too costly, right? So some also say that multiple cycles of ovarian stimulation may be needed to obtain a sufficient number of oocytes. Some are recommending a maximum of 4 oocyte retrieval cycles, an ideal number of 20. Okay, so this 15 to 20 is always in the picture. So it allows the too little will limit the success rate, too high will be compromised because of the cost and the possible harm. Okay, what about the safety? So studying the outcome of children born from comparing frozen from fresh oocyte, they found that there was no significant difference with regards to obstetric outcomes or neonatal outcomes, meaning there is no increased risk of birth defects or pregnancy complications with frozen oocytes. What about the risk of aneuploidy? Again, there is no significant difference in aneuploidy rates from frozen oocytes, 29%, versus fresh oocytes, which is 26%. Okay? And if we go by recommendation, ASRM agrees that based on the present data, the neonatal outcomes seem to be the same with fresh and frozen oocytes. How long can we store the eggs? So that is the question of a lot of our patients, right? So there is no adverse effect of the duration of oocyte freezing on the live birth using thaw oocytes. So the Human Fertilization and Embryology Authority recommends oocyte to be stored for 10 years, but this may vary depending on special circumstances. This is not universal for all countries. Some do not even have time limit of how long they can store. Okay? So if we will assess the cost effectiveness of doing the procedure, thawing the oocytes, and how much it costs, this is one study showing that the overall usage rate was only 8.4%. And those who thawed their oocyte, there was a live birth rate of 31.5%. So if you will see here in the table, the cumulative live birth rate is increased as the woman is younger. And of course, the cost is increased as the woman is older. So again, we emphasize on the age, to be more cost effective and to have a higher success rate. Now, with regards to the indication, is there a difference in the outcome if the indication for fertility preservation is due to medical or oncologic versus social or planned oocyte cryopreservation? So this is a study by Kobo, and the results were as follows. So those who had elective fertility preservation, so this is social egg freezing, they were older compared to those whose indication was for cancer. The usage rate was 12.1, which is higher than the 8.4 in the previous study, and the mean storage time was 2.1 years. So with regards to the reason or for the indication for fertility preservation, there was no effect on the oocyte survival rate or the cumulative live birth rate. The age is the one that had an impact. So the younger the woman, whether it be oncology indication or non-oncology, it resulted to a better oocyte survival rate and a higher cumulative live birth rate. So fertility preservation was effective in safeguarding fertility in both elective fertility preservation and oncology fertility preservation. Age was the most powerful confounding factor, and they said that the results were better also if there were more oocytes. So based on this study, the authors recommend that women should be encouraged to vitrify the eggs at ages 35 or younger. As to the exact role of cancer disease on IVF, more research is needed. This is the most recent that I saw, a 2022 systematic review on the oocyte cryopreservation outcomes comparing medical indication and social indication. So what were the results? They were similar, whether the patient was before cancer treatment or undergoing planned oocyte cryopreservation. There was insufficient data to predict the live birth rate or the number of oocytes to have that live birth. So they found out that the oocyte yield and the live birth rates were best among women younger than 37.5 years or had a relatively good AMH level at the time of oocyte retrieval. There was also note of a high no-use rate, meaning it was not used, almost 60% in social egg freezers, with 62.5% returning to use their frozen oocytes with a spouse. The utilization rate in the medical OC patients was also low at less than 10%. I would just like to share with you our CARMI census for oocyte cryopreservation. So you see here, we have an increasing number of cases. For 2022, this is just from January to July, which already is the same as the one of last year. So there was a decline during the pandemic. Majority of our patients fall into the younger than 35 age bracket, and then next in line are the 35 to 37. So these are the ideal ages to have the oocyte cryopreservation. The AMH, 1.2% more, 67% had a relatively better AMH levels. Okay? Primary indication was the advanced maternal age. So this was the planned oocyte cryopreservation. And second in line was the endometriosis. The rest are for cancer indication. Okay? With regards to the retrieval, so the average retrieved oocytes were 11, M2 was 8.6, okay? And the survival rate after thawing is 82%, which is roughly comparable to reports. So in summary, oocyte cryopreservation is an established method of fertility preservation for both medical and non-medical reasons. It's considered the most established technique in women who want to freeze their eggs for medical reasons. The woman's age at the time of the storage and the number of mature oocytes are the most important predictive factors for success. So clinicians should counsel patients regarding the impact of cancer and other diseases and the treatment of this for the fertility of the women and their fertility options. We should also discuss the pregnancy after gonadotoxic treatment or their underlying benign conditions. There is a strong need for women to be fully informed of the likelihood of success as well as the costs and the risks. Thank you very much.